we move on to Dr. Sumita Agarkar. Often we face children with unexplained vision loss. How do we go about these patients, these children? Over to Dr. Sumita Agarkar.
Good morning, and thank you, Dr. Laila, for considering me. I am not a neuro-ophthalmologist. I am a pediatric ophthalmologist, so feel free to correct me. There is a bit of overlap. So how do you define unexplained visual loss? So it is a visual impairment that occurs out of proportion or in absence of any objective ophthalmological findings, and it can be unilateral or bilateral. But usually when we look at children in the clinic with unexplained visual loss, our first thought is uncooperative, second thought is malingering, but really these are the last, should be the last on your mind. Children may not tell much, but when they say, okay, I don't see well, you should believe them most of the time. So when you look at the unexplained visual loss, always think of horses versus zebras. It could be an uncommon sign of a very common disease, or it could be a common sign of a rare disease. So both exist. So let's look at a case, this 4-year-old male child who has come with both eyes poor vision, but right eye low vision noted by the parents, a little outward deviation of the right eye. No history of any of these things, perinatal period uneventful, normal developmental milestone. Visual acuity is 2/60 and 6/18. This is his refraction. Has some definitely RXT. Ocular movements are full, anterior segment normal, and these are his fundus pictures, which doesn't look anything majorly abnormal. We gave glasses, part-time occlusion of the left eye, but what I don't like is that he's still 6/18 in the left eye, where I can explain 6/60 in the right eye with that exotropia. But 6/18 OS, a child who has been wearing glasses, no major things, compliance to glasses patching good. So this time we check color vision, which is not really, we check it every time. And now he reads only a test plate. So we do a fundus photo with AF, and you can see there is a macular dystrophy there, which is beginning, which is not visible on his fundus pictures if you remember last. This is his ERG, not a very good recording, but because he was not very cooperative, but you can definitely see the pattern of reduced scotopic and photopic response. I need to repeat it at some point, but we know that vision is, we are dealing with some kind of retinal dystrophy here and not just astigmatism or exotropia. So workup in an unexplained visual loss is nothing great. It means only these 4 points: a good comprehensive history, a comprehensive ophthalmic examination which is not directed towards symptomatic checkup, proper selection of ancillary diagnostic tests, and last and foremost what we call as gut feeling, or basically red flags and high index of suspicion where you need to see. So good history is irreplaceable, and history should include all these points: history of consanguinity, family history of first degree relatives of poor vision and nystagmus. This is often not volunteered, but if you ask, you might get the history, and that almost tells you the diagnosis straight away. Similarly, history regarding symptoms which may not be volunteered are photophobia and night blindness, which unless you ask a guided question, they are not going to tell you. So comprehensive ophthalmic examination means eye exam which you do it in a textbook. Visual acuity, definitely do not take every attempt to do a visual acuity, both eyes. Interocular visual acuity difference is more worrisome than poor vision in both the eyes. If one eye is 3/60 and other eye is 6/18, I will worry about that. I will not worry about 6/12 OU both eyes. Color vision, very important part if you are looking at unexplained visual loss. Cover test, madam has already alluded to sensory examination, and I don't want to go into detail. Pupils, again, very important sign, and we all forget because we let our optometrist check it. But if it's unexplained, next time please do it yourself. A cycloplegic refraction and a dilated fundus evaluation. Diagnostics which help you: neuroimaging, imaging, like I said, autofluorescence imaging, photographs sometimes, electrodiagnostics, VEP and ERG, irreplaceable. Visual field examination, even if child is uncooperative, you can definitely do a confrontation test, and OCTs and many other evaluations which are now available. So this is a comprehensive list of things which can appear as if they are unexplained visual losses. When I say normal looking eye, it is just that they are in an earlier stage of their disease, that you don't pick it up, you don't see it, it's not staring at your face, or things may be subtle and you will see them only if you look for them. So this is a comprehensive list where children can present with unexplained visual loss. So what are transient amyloidogenic factors? These are some during infancy or early age. They might have any of these things: a lid swelling, a macular hemorrhage, a transient strabismus, which is hemorrhage which has gone away but has left the child with some deficit from that time, and often these children are monofixators. So next thing which you have to look for is monofixation syndrome. So this is basically facultative scotoma. You may have a unilateral slightly poor vision, or maybe densely poor vision. There is often subnormal stereoacuity, retained peripheral fusion, and the diagnostic test for looking for this kind of suppression or monofixation is to do a 4-prism base out test. So you can look at this history. 11-year-old, again 6/24, he is slightly anisometropic myope, orthophoric, but does not explain despite patching. Vision 6/24, vision stereo is 200 arc seconds, anterior segment fundus examination look normal. Refraction does show a little bit of anisometropia, and this is how you will do a 4-prism base out test. So right eye is a non-fixing eye. So when you place the prism over his right eye, you don't see any movement, but when you stay, you can see that slight flick divergence with a no refixational saccade, which should happen. So this vergence movement in one eye when you place the prism over normal eye, and no movement when you place the prism on poor eye, is what it shows you that there is a monofixation. It does not tell you microtropia. It tells you that patient has suppression scotoma in that eye. So this is also very, very important test when you are looking for if child is monofixator, where there are not obvious anisometropia, strabismus. You can still demonstrate that child can be amblyopic. Now refractive errors, sometimes ametropic amblyopia, meridional amblyopia, they all can come as slightly impaired visual acuity without, and a lot of these will improve with glasses and patching sometimes occasionally. So this must be again looked for, and they can also appear as if normal visual. So a small tip here and a learning lesson here. This is a 4-year-old routine exam, because he is a sibling of one of his brother who has a refractive accommodative esotropia, and this is his refraction. He is ICS on cover test. I give him glasses, full correction, patch right eye, follow-up visit. He is orthophoric with glasses, vision 6/12, refuses to budge. 2.5 years go by, now he is 8, visual acuity is still same. And now I actually put a minus 0.75 diopter over his glasses, and lo and behold, visual acuity improves. So some of these children who have been wearing hypermetropic glasses for a while and vision doesn't improve, maybe a year or down the line, you should probably look at, and when they are a little older, they might do a little better with a slightly under-corrected hypermetropia rather than the full corrections which we tend to give in these situations like here. So amblyopia, of course, I don't need to go in detail, but here also visual acuity is equal, and you have to look for small signs, subtle signs for exotropia, anisometropia, and other monofixation. So coming to keratoconus, again, early keratoconus may just present as high cylinder and not improving vision. Clinical signs which we read classically of Vox dry and all may not be present at all. But we have to keep a high index of suspicion in patients who are eye rubbers, or who have atopic disease, or have Down syndrome. Scissoring reflex on retinoscopy is a giveaway. Topography is diagnostic, and contact lenses almost improves vision fully in these patients, and you should probably ask for a RGP lens trial rather than a soft lens. Juvenile open glaucoma, steroid-induced glaucoma, post-traumatic glaucomas also can present only as progressive myopia in older children, and when in the presence of myopia, sometimes it's difficult to assess the disc, and intraocular pressure must be checked in these situations. Disc evaluation, difficult sometimes because of coexisting myopia, but you must make an attempt to look at the disc. Often these children with advanced glaucomas have more pallor than cupping, and this finding must be noted. You should do a gonioscopy. This kind of gonioscopy with fulminant iris processes 360 degree often points towards juvenile open angle glaucoma. And of course, I don't want to go into great detail about how to manage glaucoma, but this is also something you should look, because we don't check intraocular pressure routinely in children. So you should do it if it is progressive myopia and no improving vision. Sometimes subluxated lenses. This child, if you see him without dilatation or poor dilation, you will miss this subluxation. Visual acuity is not improving because there is bilateral subtle subluxation of the lenses. Of course, now when you have seen the subluxated lenses, you will see tall stature and everything else, and then you will ask the history, and yes, father also has bilateral aphakia with retinal detachment, but here don't rush into do SFIOL. Plus, first do a good refraction and give them glasses. They often always improve with glasses. Retinal pathology, retinal dystrophies, they are also one very large group of patients where there is unexplained visual loss. What are the red flags? Where do you suspect retinal dystrophies? Visual loss, high or even moderate myopia, hyperopia, subtle nystagmus, a normal fundus, often normal fundus. This does not rule out retinal dystrophies, and poor color vision, and family history of first degree relatives having any of these symptoms or actual visual loss. So these are something which you will get only in the history and not volunteered. Can I have 2 minutes? So this is a patient, again 13-year-old, normal looking fundus, but when you do her AF, you can see that there is a macular pathology, and we do ERG, which is normal because it's just macular pathology, but look at multifocal ERG, which is showing a clear depressed response at the macula. OCT shows thinning, and when we do genetic testing, it is suggestive of achromatopsia, and you can see father has mutation, and you're out. You change, you don't look at -9 there, don't go for atropine here, look for why she is not improving vision. This is another case. This is the history, this is his refraction. Anterior segment looks normal, posterior segment looks also on and obviously normal. There are some lattices but otherwise normal. But look at his ERG. A classic negative waveform on suggestive of complete CSNB, a decreased rod response and nearly normal cone responses. So these are all the retinal dystrophies which can present with normal looking fundus, especially in children. In adults, when they see them, you will have clinical features, but in children they will have normal fundus. So these are your red flags for looking at retinal dystrophies. Now coming to neurological neurodevelopmental issues, all of these can often have subtle signs and you may miss it. Optic neuritis, especially if it's retrobulbar and symmetrical, you may miss it. Leber's optic heritage, again here history is important. So this is 7-year-old. Treated for vision dropped suddenly, and color vision again here is a very important sign. RAPD is not gross here, it is trace, and if you would miss it if you don't look for it. But if you look at his fundus, this is his fundus. There is no edema, no nothing, but vision is 2/60, and this is where you should look at neuritis as a bilateral involvement in children is very common, and you should look for it. This is his VEP. MRI showed definitely, and MOG antibodies were positive. He received IVMP and did improve vision in both eyes with appropriate treatment. Supracellular tumors can sometimes present as very subtle disc pallor. 15-year-old, 7 months history, has a small RXT but poor vision. If you look at our fundus, when I tell you after the history, you will see there is a pallor in the right eye, but if you miss it in a busy OPD, you might say there is discs are looking normal, there is no papilledema or anything. These are her fields because she is older, and MRI was sure enough was suggestive of craniopharyngioma. CVI, again a big group where patients can have very little signs in the eye. In fact, optic nerves almost always are normal and strongly associated with prematurity, hypoxia, sepsis, neonatal, eventful perinatal period, and history will point to the diagnosis here. So mechanism of injury is this, and you can see periventricular leukomalacia if you do an MRI. An MRI should be warranted at least to document what is the reason. So spectrum can be ranging from mild to severe. You can have motor involvement, you can have CP-like picture, you can have absolutely normal high functioning CVIs also. Optic nerves almost always look normal, or there may be a subtle pallor, but there are overt neurological issues almost always. So neuroimaging is essential. VEP is easy and non-invasive, but may not be very informative if you are looking at CVI. So these are the causes, and if you have ruled out all of them, then you have to look at functional visual loss or malingering as the last diagnosis. And here you have to have some stressor which is, or some gain which is to be gained. Children often don't have gain, but they can have stress points which they have, and this is a battery of tests to look at. Simple tests like madam mentioned, stereopsis. If stereopsis is good and he is saying I can't see anything, you know it is not possible. Similarly, looking at fogging or simple plus minus combination of glasses, if you put, lot of times children will read it. So some of these tests you can do very easily in the clinic in 5 minutes, like for fogging. Start with +10 and go on reducing till he becomes 0, and then he starts reading. That's a very simple test. But there are some children who are very hard to crack, and if there are real functional issues there, first rule out everything organic by doing appropriate testing, even though you think it's it is important in children not to miss things, as I showed in so many things. So do all the tests, but once it is there, probably you need a multi-speciality or a more professional approach to children who are having functional visual loss due to something which is triggering or so disclosing to family and patient. Probably it is beyond our call here, and you should let a professional handle these children. Thank you very much for your attention.
Thank you, Dr. Sumita. You have to go back.
Yeah, and I can take question.
So I think for now we'll have 2 or 3 questions now and then proceed with the next. Any questions from the audience?
Madam, how long do you wait for the refractive adaptation? Like some children, they don't improve beyond 618, 624.
You know from the type of refractive error, a child who is anisomyopic, refractive adaptation is just around 6 weeks. They will improve in 6 weeks. But child who is wearing +6 for the first time, you have to give a little longer time, maybe 4 months. I will still wait for pushing on the, if everything clinical examination is absolutely normal, history doesn't point to anything. I don't see anything like oculodigital reflex, wandering nystagmus, and vision is 618. I will still give it a year for plus hypermetropia. Okay. Astigmatism also I will give around 6 months. But if they are not improving beyond that, then probably yes, you should probably look at, first thing is to go back to the patient as a new patient. Look at it, everything back again, and then probably press the panic button about investigations. We are so sure about our findings, we never look back at it. I have missed disc pallors several times. So if it doesn't match, if you think that this cannot cause amblyopia, don't label it as amblyopia. Amblyopia doesn't behave that way. Seek second opinion. Sometimes somebody sees it with a fresh eyes.
Yeah.
You pick up findings.
Better to say.
After treating refractive errors for a long time, like for 1 year, 2 year, even after giving citicoline and all, if the patient is reaching up to 612 and 69 OU, both the eyes,
I won't worry about that. A lot of those patients, if you watch them till they are teenagers, they will become 6'6".
Then we need not to do.
But yeah, rule out everything else.
But then parents are like, why they are not?
That's what I said. I will worry about unequal vision. I won't worry about 612.
Thank you.
If everything is okay, all riders are, everything else is okay.
Also, there is this tendency for labeling patients as bilateral amblyopias and then patching alternate. I have never found that to be at all helpful. As I completely agree with you, Sumati, that I would just leave these children alone and let them grow into 6'9" or 6'6". But I get patients with bilateral and they are miserable because kids don't like a patch, and patching each eye one day this, one day that really doesn't help.
When you work in the same institute, you see the vision improving, like it improves with time. When other things are normal.
In my early ages, when I was younger, I used to give alternate patching. I won't disagree with. The question is valid. When I was that young, and I used to sometimes really stress patients ki vision not improving, especially high astigmats who have -4 astigmatism both eyes. They will move to 612 +2 and then kind of stop there. And so I think you have to just reassure the parents that over a period of time it will come to 6'6" part, and it will not interfere with their educational or career choices. I think that's a little bit of chair time is required. I still give alternate patching, though I agree with him, but sometimes if parents feel that we are not doing anything, if they seriously are coming from Bihar and kuch nahi. Okay, do alternate patch, do some vision therapy. But honestly, I also know that.
Thank you, Dr. Sumita, for that wonderful talk.